Slide आइरहेछ slide आइरहेछ
Or yes, sir.
आइरहेछ है So now we are starting today the another airway disease. So that's mainly one of the commonest disease which you are going to encounter in your clinical practice in medicine. So this is a chronic obstructive pulmonary disease. So starting with COPD, so first starting with a definition, and then we'll go with the pathophysiology shortly, and then the spectrum of COPD, and then also we are going to discuss the clinical features, what are the risk factors, and that's what the investigations that you are going to do, and what are the complications of the COPD and the guidelines. So mainly we are following the gold guidelines for COPD. So GINA for asthma and GOLD gold guideline, which is updated every yearly. Okay, so every yearly, so that will follow that for treatment protocol, and then the management of acute exacerbation of COPD, one of the commonest presentation. Okay, so with this we'll conclude the today's lecture. So starting from the definition, so this is the definition which is given by the gold. So COPD is a common preventable and treatable disease. So it is a treatable disease that is characterized by persistent respiratory symptoms. Okay, so there should be a persistent respiratory symptoms should be there in the patient, and there should be a airflow limitation. There should be a airflow limitation that is due to airway and or alveolar abnormalities. Okay, so usually caused by the significant exposure to the noxious stimuli. So there should be a significant exposure to the noxious stimuli should be there. So definition ma ke hunu paryo. So what are the things that should be there? So there is a persistent disease which is mainly a progressive disease and has an airflow limitation, and there should be a history of significant exposure to any noxious particles or gases in the forms of smoking or in the form of any occupational exposures or any biomass exposure. Okay, so that might be a possibility. So should be there in the history to complete the diagnosis. So as you know from your basic science, the chronic obstructive pulmonary disease has a two spectrums. Disease spectrum. They are chronic bronchitis and emphysema. So for the definition of chronic bronchitis, it is clinically a condition where there is a presence of cough and sputum production for most days over 3 months for 2 consecutive years. Okay, so if we are getting this in the history, then you can think this is predominantly I am getting the spectrum of chronic bronchitis in the background of COPD. Okay, while emphysema is mainly a destruction of the alveolar walls, where there is a decrease of the lung elastic recoil, and there is an enlargement of elastic recoil, and there is an enlargement of alveoli, and there is a which reduces the maximal expiratory airflow. So it's mainly a pathological thing. Okay, so emphysema. So there will be mainly a destruction of the alveolar walls and permanent dilatation of the distal bronchioles. Okay, is mainly a emphysema. So with this background, so as you know, so this is the airways. So mainly the bronchioles and the bronchus is mainly affected on this. Okay, so affected on this. So what is chronic bronchitis? So in the chronic bronchitis, there is always a mucus builds up in there, and there will airway muscle tightens up, and then the airway lining swells up, leading to the inflammation, and there is causing a damaged airway and leading to the airflow limitation. So while in the emphysema, there is a healthy alveolus is there. In this, there will be alveolus is damaged by the pulmonary disease. So there is a distortion of the terminal bronchioles. Okay, so terminal bronchioles, and then there is a collection of the mucus. So the air is also entrapped here, and there is a air cannot get out, and there is a obstruction out here in the emphysema. So the airway air is going to be trapped inside the alveolus, and then it is going to enlarge, and at last there might be a formation of bulla. Okay, so and that might rupture and lead into pneumothorax. So that's mainly a complication of emphysema. So what are the risk factors? So risk factors mainly is a smoking, and then the another is a biomass fuel, in which in our villages the mostly they are using the all these woods, and then the also cow dung for the cooking source. Okay, so the biomass fuel is the another one, and the pollution, and then the another is the occupational exposure. So all these are the risk factors for COPD. And along with that, in the younger years age group, so if the lung growth and development is impaired, so that also pre-exists to develop COPD. And if the patient is having a history of asthma and is not controlled, so that land into chronic asthma, and that may land up into the COPD. So British guidelines also put as a chronic asthma as another spectrum of the COPD. Okay, so COPD. So these are the risk factors. And then the persistent repeated infections also causing the damage to the bronchioles, leads into a COPD. So that may are the risk factors. So what is the pathogenesis of COPD? So if there is a cigarette smoking, if there is a biomass particles and particulates, that leads into the into a lung inflammation by the activation of these inflammatory mediators from the neutrophils and macrophages. And this mainly produces the two things, that is, one is the antioxidants. Oxidative stress will be there. So antioxidants, if you use that will decrease the oxidative stress. And the another is a proteinase enzyme. Okay, so that's mainly leads into a destruction of the alveolar walls, leading to emphysema. So all these are the mediators and these enzymes which are mainly responsible for the pathogenesis of COPD. So coming to the etiology, the smoking and pollutants are mainly responsible, and there might be some certain host factors. And then what is happening is the biology is impaired lung growth, as already told in the previous risk factor, and accelerated decline of the lung function is there, and lung injury and lung and systemic inflammation. So all these leads into pathology, that is small airways disorders or abnormalities will be there. There will be a emphysema, and then there might be a systemic effects. All these lead into airflow limitation, that is persistent airflow limitation will be there, and leading into clinical manifestations like symptoms, exacerbation, and comorbidities will follow. Okay, so this is the how pathobiology will go on. So this is the curve, as you know. So why the smoking is mainly uh, important as a risk factor. So if the patient has never smoked or not susceptible to smoke, so the persistent percentage value of AP1 decline is less. Okay, so it's less for over the years. But if the patient who has having a mild COPD, and the patient has stopped smoking at the age of 45, so there might be certain chance the decline of the lung function will be there. Okay, so lung function will be there, but we can further enhance. Okay, so enhance the lung function like this. Okay, so if they stop that, so as you can go up to the level of the disability as the years progress up to 100 years. Okay, so that's mainly why. So early smoking cessation is very much advisable. So you smoke regularly and susceptible to the effects of smoke, so then the lung function is going to be deteriorated, and the disability will persist early. Okay, so early. So this is mainly the thing that we have to think about the cessation of smoking. So coming to the symptoms, so what are the symptoms the patient will present to you? Uh, what are the symptoms? So patient present with mainly a chronic cough. Okay, so chronic cough will be there. Patient will have a history of dyspnea. Okay, so dyspnea will be there. Shortness of breath, which is progressive from days to years. Okay, so it is progressive. So how we can know about the progressive is by using the modified medical research council dyspnea scale. So that I'll come in the coming slides. Then the patient will have a history of chronic sputum production. It can be a mucoid. If it is infected, it can be a mucopurulent, purulent, and purulent. Okay, so that might be the symptoms the patient can have. Then what are the signs that you are going to get in the patient while the examination? So on the inspection, you can have a barrel shaped chest. So there might be a use of accessory muscles of respiration will be there. Okay, so the sternocleidomastoid will be more prominent. Okay, so the all will be there, and then you can see the flaring of echinacea. Okay, so this will be there, and then if the patient has emphysematous changes, then the patient will have a port sleep breathing. Okay, so this is a port sleep, just like a opening of the pores. Okay, so there's a port sleep breathing, and then the patient will have a decreased cricoexternal distance. So this distance will be reduced because of the hyperinflation of the lungs, and then patient will have a it is a reduced. Okay, so it's a reduced AP and transverse ratio will be there, and the patient will have a reduced chest expansion whenever you measure the chest. Okay, so there will be a the expansion will be reduced. That will be less than 5 to 7 centimeter, and then patient will have on a resonant and on percussion and the shifting dullness of liver dullness. So ideally, shifting dullness is the liver dullness you will find at the fifth intercostal space while you are percussing from up to downwards. Okay, so when there is a emphysema, it will push down the liver, and then you are getting the percussion resonant at the level of fifth intercostal space because of the pushing of the liver by the hyperinflated lungs. And on the auscultation, you will be finding a vesicular breath sound with prolonged expression. Okay, so prolonged expression, and the added sound you will find the wheeze. Okay, so that's the mainly of a finding that you are going to. So on the inspection, you will see the barrel shape. So as a barrel shape, you can see the anterior posterior diameter is slightly more. Okay, so as compared to this picture. Okay, so this picture, so this anterior posterior diameter has increased, so this is giving the barrel shaped picture on the inspection. So this is the clinical features that you are going to find in the patient with COPD. So this is the hyperinflated lung. So as you see, this is the normal diaphragm curvature. So the flattened diaphragm will be there. Okay, so because of the hyperinflation, so that you can see in the X-rays. So as in the coming slide, so we have to differentiate whether you are dealing with the asthma and COPD. Right? So COPD, so it's not the same disease. So as a patient will say that everything the patient ले के भन्छ भने, so मलाई दम छ डर छ, dum can be either asthma or it can be COPD. So yeah, it is not the same disease, and you have to differentiate between two. So what are the differentiating features? So COPD and asthma, so is mainly a smoker. Is the COPD mostly are the smokers. In the smokers, the more common is COPD, and the asthma. Possibly, the risk factor is causes the asthma, while as the COPD is the disease of old age, while as the asthma is the disease of the start from the childhood, early childhood. Okay, so, and then the patient will have a chronic porotic cough is more common in COPD, while it's very uncommon in asthma, and breathlessness is mainly persistent and progressive. Okay, so it's a persistent and progressive in case of COPD. So there will be no any decrease or absent of breathlessness in COPD. So it can be a decrease, but it will be a persistent. Okay, so there will no absence of breathlessness. So it's a progressive disease. So if बिरामीले भन्दाखेरि कसरी भन्छ भन्दाखेरि, if the patient is telling that I have a shortness of breath, Dr. Sahab, while I am climbing the stairs 2-3 years back, so in between the patient is not symptom free. So patient is having a shortness of breath, but now I cannot even get out from the bed. So that's mainly it has progressed. Okay, so it has progressed. So that's how the definition. Okay, patient present with COPD. While in the asthma, it is a variable breathlessness. So patient will have a variable breathlessness. Patient will tell that during certain attacks, I'll be having a breathlessness, but in between I'm completely fine. So there's no any breathlessness at all. So that's the differentiating features. Okay, and the nighttime workings with the dyspnea and wheeze is very uncommon in case of COPD, while it's very common in case of asthma. And the diurnal variability is more common is case of asthma. Early morning breathlessness, cough is more common in case of asthma as compared to COPD. So inflammatory cells, mainly neutrophils in COPD, while the eosinophils in case of asthma. And the airflow limitation is not fully reversible. So whenever you are giving the nebulizer or any bronchodilator, it is not fully reversible, but it is fully reversible in case of asthma. So that's a reversibility if there is in the pulmonary function test that is more than 12%, as I told you in the asthma lecture. So if FEV1 is more than 12% improvement, so then it's fully reversible. So then we can say this is as a asthma. So there are also a term known as a asthma COPD overlap. Okay, so there is a two combination of both COPD and asthma. So that is known as a ACOS, asthma COPD overlap syndrome. And first line treatment, inhaled bronchodilators in case of COPD, while as a inhaled corticosteroids in case of asthma. So this is the differentiating points. Okay, so this is, so coming to the pathways to the diagnosis of COPD. So what the gold has given is that the symptoms. So there should be a symptoms of shortness of breath, which is chronic shortness of breath, which is progressive, and then the history of chronic cough, and we have to exclude the other causes of chronic cough, and there should be a sputum production or without sputum production, and then there should be a risk factors. Okay, so risk factors should be there, like host factors, tobacco is consumption, occupation, and then the indoor or outdoor air pollution. If it is there, then you do the confirmatory by the spirometry, and if there is a airflow limitation, your FEV1 by FEC ratio is less than 0.75 or 70%, then we can confirm the diagnosis of chronic obstructive pulmonary disease. So key indicators for considering a diagnosis of COPD: consider COPD and perform spirometry if any of these indicators are present in the individuals over age 40. And these indicators are not diagnostic themselves, but the presence of multiple key indicators increases the probability of the diagnosis of COPD. So spirometry is required to establish a diagnosis of COPD. So dyspnea that is progressive over time. And so progressive over time is there and characteristically worse with exercise, and it is persistent. Should be persistent dyspnea will be there, should be there. And patient have a chronic cough which may be intermittent and may be unproductive, and patient will have a recurrent wheeze. And the chronic sputum production, any pattern of chronic sputum production may indicate COPD, and the recurrent lower respiratory tract infection can be there. And history of risk factors like host factors such as genetic factors, congenital, okay, so and developmental abnormalities is there. Tobacco smoking, including popular local preparations, smoke from home cooking and the eating fuels. And so local preparations means tobacco is mainly a bidi and all these things. Okay, so and there is smoke from the cooking and heating fuels, occupational dust, vapors, fumes, gases, and other chemicals. So these are the history of risk factors should be there, and family history of COPD. For example, low birth weight, childhood respiratory infection, etc. Are also the risk factors. Okay, so the family history to have a COPD. So for the lab investigation, what you are going to do, so you can do the hemoglobin. So what is the rationale of doing the hemoglobin? So it can be increased in the case of secondary polycythemia. As you know from your basics, so when there is a hypoxia, there will be a activation of erythropoietin. Okay, so erythropoietin, and the erythropoietin increases the hemoglobin. So that's why there is a secondary polycythemia. So that's the one of the complication of COPD. And the differential counts can be also give you the whether you are dealing with infection or not, if your total leukocytes counts increase. Renal function test, uric creatinine can be deranged. Okay, so if there is a any infections leading into acute also important, because the sodium can be decreased because of the uh, use of any diuretics in the patient with COPD, or because of the subacute systemic inappropriate secretion of ADS, SIDH. Okay, so sodium can be reduced, or potassium can be reduced because of the use of bronchodilators. Okay, so that's why you have to use do the renal sodium potassium. And then the sputum profile, so to see whether there is an organism which is responsible for the acute exacerbation, gram stain, FE stain, culture sensitivity, and atrial blood gas analysis to look for whether the patient is a respiratory failure or not, whether the patient has a PO2 is decreased or not, whether the patient is respiratory acidosis is there or not, or the patient has a PCO2 increase, that is the hypercapnia leading into a CO2 narcosis is there or not as a complication. So that is the that will give you the diagnosis. And then the chest X-ray, we have the certain findings of the chest X-ray. So what you are going to look in the chest X-ray. So this is a normal chest X-ray that you are going to look. So this is the mainly a heart is there, and there's a lung parenchyma, and there's a okay, thoracic case. Okay, so thoracic case. So reading the X-ray, so you start from the outside to inside or inside to outside. Okay, so the soft tissue is absolutely fine. So on the rib case, what you are going to get is mainly a hyperinflated. So the distance between the two intercostal space will be widened in the case of okay. So the widened okay, spaces between the two intercostal space is widened, and there is a flattening of diaphragm will be there. Okay, so this is the picture where it's showing the flattening. Ideally, the right side of the diaphragm is upper than the left side. Okay, so it's a flattened diaphragm you are going to see, and then you also going to see the tubular heart. Okay, so tubular heart in the case of emphysema. So these are the and in the case of bronchitis, you see the increased bronchovascular markings. Okay, so increased bronchovascular markings in case of the bronchitis. So these are the chest X-ray findings that you are going to have. So then the CT chest you can do. So CT chest is ideally not okay, is a gold standard to do in every cases. So if you are suspecting of any other complications like mass or anything then you can go for the CT chest, and then you can go for the electrocardiogram ECG. So ECG is mainly important to look for any arrhythmias. Okay, so arrhythmias, and you can see the enlargement of okay right atrium or ventricle on the ECG by showing the right ventricular hypertrophy or not. And then the echocardiography, that you will confirm if there is a right ventricular hypertrophy, you will confirm by the echocardiography. And also you can look for the pulmonary arterial pressure. Okay, so pulmonary arterial hypertension are there or not. So with this, so these are the modalities of the investigations that you can do. And then for the confirmation, you have to do the spirometry. So spirometry, so you can do is mainly is required to make the diagnosis. The presence of the post bronchodilator FE1 by FVC should be less than 0.7 to confirm the obstructive airway disease. Okay, and then after that you are going to do the things. So these are the things that you are going to do in the PFT lab. Okay, so the spirometry lab most likely you have done in your basic science, so there should not be like a big drum or thing. So you can do in the computer settings in our okay PFT lab, lab in hospital setting. Okay, so what you are going to look, so this is the flow volume curve. Okay, so time volume and flow volume curve. So these are the things that you are going to look, FE1 by FEC and FE1 by FEC ratio that you are going to look in the flow of normal tracing. And so this is normal tracing, and this is the abnormal tracing in the obstructive airway disease. So this is the flow which is okay decreased. Okay, so expiratory volume is decreased as compared to the normal flow. So this is the thing that you are going to look. So with the basis of this is that you are classifying the airflow limitation and the severity of the COPD on the basis of spirometry. Okay, so spirometry. So this is the gold staging for the severity of the disease. So according to that, your treatment protocol is going to be there. So gold one is that mild, so it is mild. So in every case there should be a FE1 by FEC should be less than 0.7. Okay, so 0.7, and you will get the, after giving the bronchodilator, your FE1 is more than 80% of the predicted. So then you can say this as a mild, and if it is 50 to 80%, between the 50 to 80%, then you can say is as a moderate, and then the severe is the FE1 is between 30 to 50% of the predicted is a severe, while as a very severe, if FE1 is less than 30% of the predicted is a very severe, is a disease. Okay, so is a gold class okay, 4. So this, and for this after this, so then for the progressive disease you use the modified MMRC dyspnea scale. Okay, so dyspnea scale. So what is MMRC 0? I only get breathlessness with exertion exercise. So this is the dyspnea scale that you are going to for the symptoms. Okay, so MMRC grade 1, I get short of breath when hurrying on the level or walking up slight hill. Grade 2 is I walk slower than the people of the same age on the level because of the breathlessness, or I have to stop for the breath when walking on my own pace. So it's a grade 2 MMRC grade 2. And MMRC grade 3 is The if the patient is having to stop to breath after walking about 100 meters or after a few minutes on the level, so is a grade 3. And grade 4 is I'm too breathless to leave the house, or I am breathless when dressing or undressing, is a grade 4. Okay, so if the patient firstly has a grade 1 dyspnea, so now it is persistent and it has traveled to, okay, is presently it is a grade 4, so it has progressed from 1 to 4. Okay, so that's how you are saying is a progressive dyspnea. So coming to the another assessment of the symptom assessment, so that is given by the CAT. Okay, so CAT in the CAT assessment. So for each item below in the box is describes currently how is you give the certain score for this. Okay, so I never had a okay, I am very happy, I am very sad. Okay, so on that I never cough. So you come to this, I cough all the time, you score either 5. Okay, so this is how you are going to score. So my chest is completely full of the flame. Okay, so full of the flame is 5. Okay, so my chest is physically limited time in my lungs. Okay, so and then I don't sleep soundly because of my lung condition, I have no energy at all. So this you give the point treatment management. So there's a ABCD protocol, so that will come on the coming slides. Okay, so this is